We're taking a brief interval from our Confidence Interval podcast series to share the important research that's happening around obesity and diabetes. I'm Pam Mungrew, and I'm on a quest to find out more about the research happening at the MRC Epidemiology Unit and the IMS Metabolic Research Laboratory at the University of Cambridge. I'll let my guest introduce herself.
So my name is Charlotte Boughton, and I'm an assistant professor in diabetes at the University of Cambridge, and I'm also a diabetes consultant at Addenbrookes and at Papworth Hospital, and my research area is in diabetes technologies.
Charlotte's research focuses on the use of automated insulin delivery systems with the aim of improving outcomes for people with diabetes. Leading randomized controlled trials, Charlotte is evaluating the efficacy and the safety of the delivery system for people with type 2 diabetes.
So we work with automated insulin delivery systems, which simply put are made up of three different parts. One is a glucose sensor that's worn normally on the arm and monitors the glucose levels in the body every minute or 5 minutes. And then that talks to an algorithm or a computer program, which in our case is an app on a smartphone. And that then tells an insulin pump how much insulin to give to keep the glucose levels in the target range. The insulin pump, most people wear it. It's a tiny cannula that's normally worn in the tummy, and then there's a small pump about half the size of a mobile phone size, which delivers the insulin. So this sort of technology has been worn by people with type 1 diabetes, insulin pumps for the last about 20 years. And then over the last sort of 5 years, more and more people are using these automated insulin delivery systems. They're sometimes called closed loop systems as well, because every 10 minutes, the system repeats that cycle where it reads the glucose levels, works out how much insulin to give, and then tells the pump to give the insulin, and then it reevaluates that all through the night. And the person wearing it doesn't have to do anything. That happens all automatically, so long as they're wearing the devices.
You've just given one of the benefits of wearing the device, and I appreciate that the next question I'm about to ask you is a little bit daft, which is, what are the full benefits of having this constantly monitoring your sugar levels, your glucose?
So previously, when people had to do finger pricks, they're painful, and you would often have to do around 8 finger pricks a day if you were somebody that uses insulin to manage your diabetes, to make sure that you're not going low and to try and keep your levels in the recommended target range as much as possible. And so when you're doing 8 finger pricks a day, it's really challenging. So what this does is not only gives you glucose levels all the time with just one very minor, not very painful insertion every 10 days or 2 weeks, but it also gives you a trend arrow. So not only will it tell you that your glucose is 10, but it'll tell you your glucose is 10 and it's dropping, or it's 10 and it's going up. So that level of information is so important for people with diabetes to understand what's happening minute by minute rather than every 4 to 6 hours. That part has really transformed the way that we're managing diabetes now, and allow people with diabetes to understand so much more about how what they're doing day to day impacts on their glucose levels, whether that's what they're eating, what the effect of exercise is, stress, hormonal variation as well across the menstrual cycle and in menopause. So it's really allowed us to learn so much more about diabetes. And then from the pump side of things, so we wouldn't use it normally for people who don't require insulin, but for anyone who's using insulin and has to do injections several times a day, it obviously reduces the amount of injections that they're doing, but it also allows much tighter control of the glucose levels. So people end up with better glucose outcomes when they're using a pump, and less risk of low glucose levels or hypoglycemia.
So I understand that when you wear the sensor, you've got your smartphone, your glucose levels drop, the sensor sends a signal to the phone then sends an alarm to you and won't stop alarming until you've eaten something, you've drunk something to raise your sugar levels. By having the pump, does that literally mean that the minute it realizes the glucose level has dropped, it will automatically dispense what you need to bring it back up? Or is it about it just doing the doses on a regular basis?
So it's a really good question. So the pump can't remove insulin that's already been given, and it only contains insulin. People have looked at developing pumps with two hormones in, one to make the glucose levels go up, and that's called glucagon. But it means people have to wear two pumps or do two set changes. It's much more complicated, much more expensive, and a lot of people wouldn't tolerate that level of complexity, and from an NHS point of view it's quite expensive. What the system will do though is, because it's predicting what's happening in the future based on sort of trends and things that have happened in the past, it will have stopped giving insulin well before somebody's low. So if you give an injection of insulin, you can't take that insulin out. Whereas the system, if it sees that your glucose levels are going down, it will stop giving insulin, and most of the time before someone ends up going low. People do still have low glucose levels on these systems, but it tends to be less frequent than they would do if they were using injections.
You've mentioned the fact that primarily this has been developed for people with type 1 diabetes. So now you're doing research to see how it could work for those with type 2 diabetes. Why the difference, and what are you finding?
Our system was originally developed for people with type 1 diabetes, and particularly focusing on children with type 1 diabetes. But what we also did was develop a system that works in the hospital setting. So when people come into hospital who have diabetes, it's really difficult to get the glucose levels in the target range because they're unwell, they're often not eating as much as possible as they would do normally, their medications are changed. So Raymond Havorka developed a second system that's designed to be completely automated for use in hospitals, and that was really designed for people with type 2 diabetes. So all we're doing now is taking that system from a hospital setting and giving it to people who use insulin when they're at home doing their normal day-to-day lives. And we did a small study around COVID time with 24 people with type 2 diabetes who use insulin, and it showed over an 8-week period that they doubled the amount of time that they spent in the recommended glucose range when they were using this system compared to when they were using their own insulin injections and finger stick glucose monitoring. So on the back of that, we're now doing a really big study with over 200 people included in the UK, in Europe, and also in Australia, to see whether we can show that this can help people with type 2 diabetes, and ultimately that NICE, who tell us what we're allowed to offer people with type 2 diabetes, will say that this is an acceptable treatment. Up until now, nobody with type 2 diabetes has got a insulin pump on the NHS, and very few people meet the criteria for being allowed to use a glucose sensor with type 2. And we think that's a real discrepancy in access. And since type 2 diabetes disproportionately affects people from lower socioeconomic backgrounds or minority ethnic backgrounds, it's a really uncomfortable reality that people with type 2 diabetes who use insulin do not currently have access to the same technology and opportunities as people with type 1 diabetes. And that's why we feel really strongly that we want to move this area forward so that people with type 2 have access to these really great technologies.
There's a lot there to unpack. So I'm going to start first off with, why the difference between type 1 and type 2 diabetes?
It's a good question, and probably there's lots of factors that come to play. I think one thing that we shouldn't ignore is around stigma. And I think the public perception of type 2 diabetes is still influenced by people saying this is a lifestyle condition that's affected by people's choices, which is really detrimental to progress, because if we think this is about attributing blame to people and they need to find out ways to manage it themselves, then we will make no progress. And if it was really easy to make those lifestyle changes, we wouldn't have a problem. And what we do know from global statistics is that type 2 diabetes is increasing, and it's becoming increasingly common in younger people as well. So if it was really easy to manage this with lifestyle changes, that we wouldn't be in the situation that we are. So I think stigma plays a really important part of that, from both the general public but also healthcare professionals as well. There have been lots of really important improvements in management of type 2 diabetes that are not insulin based. So we have two really great classes of medications. You've probably heard of Ozempic, or the sort of skinny jabs, and they're absolutely fantastic. But there will always be some people with type 2 diabetes who need insulin. And so from our point of view, for anyone that needs insulin, let's allow them to have insulin in the most effective and the safest way possible. So those medications are great, and they have lots of benefits on the kidneys and the heart as well. So people should continue to take those. But for those people that also need insulin to manage their diabetes, then let's give them the best treatment available, irrespective of whether they're type 2 or type 1.
You also mentioned that predominantly at the moment, type 2 diabetes is being found in lower socioeconomic groups and also ethnic minority groups. Why is that the case?
So in lower socioeconomic groups, a lot of it is around lack of resources to lead optimally healthy lifestyles. So ultra processed food is cheaper. Often people don't necessarily have the resources to be able to afford and cook healthy food, and gym subscriptions don't come free. And often people's jobs require them to be quite sedentary. So I think there's lots of social factors that contribute to that. There is lots of research being done as to why certain ethnicity groups are at higher risk of it. And I think the diabetes that people have who come from Afro-Caribbean ethnic backgrounds is very different to the diabetes we see in people from white backgrounds. And we know that in other medical conditions, some medications work better in some ethnicities than others. And I think this is an area that we're sort of learning more about all the time. But we don't really know why that's the case, but there are definitely differences in the how type 2 diabetes looks and how it might be best managed in people from different ethnic backgrounds.
How do you take the different needs of diverse populations into account when you're both researching and developing equipment such as an automated insulin delivery system?
So one of the big issues that has happened in the past with doing research in diabetes is that the people included in research studies do not represent the people that we see in our clinics. So the big study that we're doing, which is called the Coyote study, we are being very proactive about making sure that the people that are included in the study look just like the people we see in the clinic. In fact, they should be the same people. And whether that means we have to go out and find those individuals, whether that means we have to better understand why they haven't wanted to be in research before, or whether they just haven't been approached to be in research, it doesn't really matter so long as we can find a way to make sure that they feel comfortable to be included in research. So we work with some interviewers from the University of Edinburgh who will be asking people who come from either lower socioeconomic or more deprived backgrounds, or those from minority ethnic backgrounds, what their experiences of using the technology is, whether there are areas that would be better suited to them in terms of the way we teach people how to use the technology, so that if the NHS do say that we can go ahead and start using this, it's not just been developed for white people who've been included in research studies. So we know that it benefits everybody, and we can make sure that the training and the rollout of it would suit everybody, so that this technology isn't then just being used in white people in the clinic. Everybody has equal access, and that's been really important to us when we were designing the trial and how we got funding for the trial as well.
You can find out more about the work of our researchers at the MRC Epidemiology Unit and the IMS Metabolic Research Laboratory by following us on Blue Sky, Facebook, Instagram, LinkedIn, and YouTube.